In a beautiful building.
All right, we're going to go ahead and get started. Thank you everybody for coming and welcome to City Club Missoula's December. I do that every single month. It's our April forum. Holy smokes. It is partnership. Yeah, it's in March, aren't we? Next. I'll get that right. It's a Partnership Health Center charting new paths in involving healthcare landscape. This one's going to go super well. Thank you all for being here. My name is Brandon Nas, Chair of City Club for 2026. And in City Club, we have a mission that brings us together, and we want to inform and inspire citizens on issues vital to Missoula, the Missoula area community through public forums that encourage the discussion of new ideas and the free exchange of thought. A special thank you goes out to our executive level sponsors, Blackfoot Communications and First Security Bank. Our executive level sponsors are key partners in helping expand audience access and public awareness of upcoming forums. We're also grateful to all of our sponsors at all sponsorship levels for their generosity and advocacy to our mission. We're excited to let you all know that Fulcrum Security has the coffee bar up here. So at any time, if you're feeling thirsty, head up here and grab some decaf. There's decaf, light roast, dark roast, whatever you'd like. MCAT, or Missoula Community Access Television, is recording our forums as part of their media assistance grant to nonprofit organizations. MCAT serves our community on cable channels 189 and 190, and you can view our past forums on MCAT's YouTube channel. A couple more kudos. The forum committee who comes in, they get all the topics squared away. We get all the panelists squared away. The board members who help set up and take down all of the tables and chairs you're sitting at right now. Our committee members come in and set those up and take those down. And then to Kristen Fitzpatrick, who's our administrator, who works tirelessly to keep the board in line, our minutes kept, and our forums organized. And again, thank you to the library, all of our members, and all of our forum attendees for attending and supporting City Club. If you're interested in becoming a sponsor or member of City Club, please visit our website at cityclubmissoula.com. Now I get to read bios. Hopefully I don't screw them up. I'm setting the bar really low. All right, so we have, is it Tara? Lara. So I said rhymes with Tara. Lara Salazar serves as Chief Executive Officer of Partnership Health Center, where she leads the organization's strategic direction and works to expand access to integrated healthcare services. She brings more than 16 years of experience in the community health center field, including leadership roles focused on strategy and innovation at healthcare serving Eastern Montana's frontier communities, as well as work with the Montana Primary Care Association, supporting health centers statewide. She's passionate about advancing health equity and strengthening systems that address both clinical care and the social conditions that shape health. Dr. James Quirk, MD. Dr. Quirk serves as Chief Medical Officer at Partnership Health Center, where he oversees clinical services across the organization. A board-certified family physician with experience spanning rural clinics, urgent care, hospital, and community health settings, he is deeply committed to improving access to high-quality healthcare for underserved populations. He's also passionate about training the next generation of physicians and works closely with the co-located family medicine residency of Western Montana to strengthen the rural healthcare workforce across the region. And Marge Bach, she serves as the Chief Operating Officer at Partnership Health Center, where she leads day-to-day operations and supports organizational performance and quality improvement. With more than 25 years of experience across hospital and outpatient healthcare settings, she brings deep experience in lean process improvement in healthcare operations. Marge is passionate about strengthening systems of care and improving experiences for both patients and healthcare teams. Dear panelists, let's give them a round of applause. And I'm not sure who's going to go first, but you have a mic, so you can go ahead and take it away.
Okay, hello. Hello. Hey, everybody. I should grab a clicker here. Is that right? Okay, just getting all the things sorted out. Hi, thanks so much for having us today, and been really looking forward to coming and sharing our story about Partnership Health Center. And I'm really excited to be here with my colleagues and friends in the audience, many of you among them. So thanks so much for taking an interest in hearing our story today. And so I wanted to start off because I suspect the point of this group is new ideas and free exchange of thought. So an exchange means that we are having a conversation. So I'm excited to present information to you, but I do want to also just ask you a couple of questions and get some ideas from all of you. So tell me, what is important to you about healthcare? Just a few people. What's really important to you about healthcare, just generally? Access. Affordability. Quality, expertise. Yes, everything that we really should be able to expect and enjoy as human beings, right? Okay, here's another one for you. Let's pretend you don't know the person sitting next to you. What would you say what would be a reason that their health and well-being is important to you?
So they don't get you sick.
So they don't get you sick? Yeah.
So your community is healthier.
So your community is healthier. Yeah.
Healthcare costs are shared.
Healthcare costs are shared. Yes. Yeah, we are only truly as healthy as any one of our community members, right? Missoula is a beautiful place. We have lots of opportunity for healthy activities, and there are still people who don't know they have access to healthcare, don't act on access to healthcare, or they believe that it's just unaffordable and they will not be able to get healthy, right? And that's really important to every one of us, right? So Partnership Health Center is really proud to be charting new paths, as healthcare should always be, right? And let's see here. Next slide. Yeah, I don't know. Is this thing on? Okay, thank you. Thanks. Right, so does anybody know what a federally qualified community health center is, or federally qualified health center? I know some of you do. Anybody want to take a risk and say what you think it is?
Accepts all forms of Medicare, Medicaid, government-sponsored health.
Yes,
issues.
and in fact, all forms of payment or no forms of payment, right? So all government forms of payment, that's exactly right. All commercial insurance, people who don't even need to be covered by insurance because they have so much money that they can just pay for healthcare outright. So we accept everyone regardless of ability to pay. And so what's really, really cool about federally qualified community health centers is that it grew out of the 1960s from the civil rights movement, where there was a recognition that healthcare must address disparities, including poverty and social determinants of health and access. Not everybody had access. And so it was addressed by President Johnson's War on Poverty, a whole lot of people involved in that initiative and making and fighting the war on poverty. We're not there yet, by the way, but in 1977, the Section 330 law officially establishes funds for federally qualified community health centers. So we receive a grant from the federal government that allows us to be able to provide care to people who have $0, right? And also to help with the issues that impact health outcomes the most: housing, health, opportunity, education, income. And so today, serving 32 million Americans, regardless of ability to pay, across the country, health centers like Partnership, and there are many of them in Montana as well. So an FQHC focuses on community, patient-led. So 51% of our board must be consumer users of PHC services, and that's the case for all community health centers. We provide barrier-free access. We are constantly working on this. This can sometimes be a challenge, right? And so that the ability to pay is never a barrier. We provide integrated care. So we'll talk more about all of the services that we provide that are integrated care, but it is treating the whole person. So 1 in 7 Americans are served by an FQHC, 1 in 5 uninsured individuals, 1 in 3 rural Americans, and 1 in 3 people living in poverty. 32 million patients nationwide, 10 million of children, 4.1 million patients over the age of 65, 1.5 million individuals experiencing homelessness, 400,000 veterans and growing. And providing mental health support is key to the idea of whole person health. We are connected, right? Our mouths, our heads, our physical body. And we've been delivering the FQHCs to 2.8 million patients also and growing, right? The behavioral health epidemic, right? And we are in need of many, many more behavioral health services and access. And screening over 72% of adolescent and adult patients for depression. We'll go more into this. So here are all the health centers in the state. So there are 13 of them. What you don't see here is kind of that blank canvas on the eastern side. That's a big health center that is merged with lots of little small health centers. That's One Health. But all of these are, and we are in very close contact with our colleagues at each of these health centers. We support each other really well to make sure that all Montanans have access. 17,000 service locations. So for example, PHC has a service location in Seeley Lake and other sites around the community. And we are the nation's largest primary care network. It's a pretty cool system. Our impact in Montana, 14 health center organizations, as I mentioned, 90 clinic sites, so with satellite sites, and critical care to over 125,000 Montanans and growing. All right, and our mission is to care for the whole person through compassion, connection, and community. And here's a bit of history, and I'm gonna use my time wisely and pass it along to my colleagues who have other great things to say. Our history. So Partnership for Access, and a lot of folks in the room probably were either a part of this or really do know this, and I'm excited that you're here. So the Partnership for Access pilot project launches in 1989. The organization, PHC, became a nonprofit in 1992. We shared space in the basement of the health department in 1993. We purchased the Alder Clinic and built that building there, which is next to the health department right now, in 1998. And the Alder Clinic opened in 99. And then we opened the Creamery building. I love these pictures. Thank you so much, Brad, for finding them and putting them in this. Isn't that cool to see this building, the evolution of it, and such a part of our history in Missoula, think that's so cool. Opens in 2010, and there were other things before us, and between the creamery and now, of course, when it was an actual dairy. PHC opens at Sealy in 2014, in our clinic in Lowell and at the POV in 2015. School-based health services began at Willard in 2019. Mobile support team launches with the help of lots of folks in this room. I'm looking at you, Josh and Dave. The food bank opens in 2021. Blue Heron Place, which is part of the Watershed campus, and school-based health services are rapidly expanding even now. We're very excited about Watershed. It's a wonderful city, county partnership, and lots of other partners, the Poverello Center, to provide day services and connecting services in our community. And independence from Missoula County, which is an exciting thing. And really what this means is that we, the county, we grew so fast as a result of being partners with the county and public health. And the county was not set up for being a primary care clinic entity, right? So we said, this partnership has been amazing, and now it's time for us to spread our wings and fly. And so it was an administrative separation, and I think we are all really going to be growing exponentially from that. So thanks so much. I'm going to hand it over to my colleague, Marge Bach.
Thank you, Lara. So I'd love to know, does anyone here use partnerships services? If you don't mind me outing you, sorry. This is not a HIPAA violation, I promise. Awesome, that's great to see so many partnership patients. What's something that you guys know, Lara kind of took us up to today. What's something that you all know about partnership besides what Lara has told us, for those of you that use our services? Anybody get a smile when they walk in the door? Okay, go. Yes.
It's super awesome. I mean, it feels like lots of other clinic settings that I've ever been in. Like the Creamery building is welcoming. You get seen quickly, or my kids get seen quickly. There's always a member of the medical team there to help them. Medical records are easy.
Oh, that's great. Thank you. I like that. Brad, put that in. I like that quote. Totally awesome. And that's great. You remind me of a situation. It was actually my kid who's been a partnership patient since she was born 18 years ago yesterday. And she was having a hard time getting to the Creamery. I don't know if any of you have seniors, but they do not have great sleep habits. And therefore, we're no showing her appointments, and showing the COO is not a great partner at our facility. So I was reminded that we had just opened behavioral health services at Big Sky High School. And so now she's able to be seen weekly right at her school. She has a couple appointments during the day, but usually sees her counselor right after school. And so she has no-shows anymore. So she's making the COO proud. So thank you for sharing. So today and last year, we saw over 18,000 patients in this community. So we went from one room in the health center basement with a couple volunteer providers to more than 55 providers and seeing 18,000 patients. We provide insurance and a sliding fee scale. Lara talked about removing disparities or removing barriers from people to be able to access services. So we do that in a couple different ways. One is, yes, we take all insurances or no insurance. We also have a sliding fee scale. So those that don't have insurance can also access our services for a low or no cost, depending on their family size and income levels and so forth. So we really try to remove that financial barrier as much as possible. This is what comprehensive primary care looks like, in case you're not sure. I think we can all agree that the American medical and healthcare system is a little bit broken, and hence you heard me say I do lean process improvement, so I've been trying to fix that one patient at a time in my career. But this is really what it looks like at Partnership. So these are all the medical care services that you can have from all stages of life, whether you're in for OB care, your pediatric patient, all the way through to geriatric. So we really cover the whole spectrum of the life cycle. We also have dental care. And what do you guys think is one of the biggest barriers for people trying to get dental care here in Missoula and probably in the whole United States? What was that? Cost. Yep. Insurance, right. A lot of dental places don't accept private insurance. And so again, what kind of insurance do we accept? Oh, and yeah, there we go. There's our take home. So you can expect to get all of the services here so that all of us can have a nice, bright, healthy smile, not just those that can based on their tax bracket. We also have integrated on-site pharmacy. So did anybody know that we have a pharmacy in the basement of our creamery building? We like to hide it well. And so those services there, it's what's called a 340B pharmacy. That means that we get support to provide our medications at low cost. We also have a medication assisted program, which helps patients get, we work directly with manufacturers to get patients their medications for no cost as well. So a lot of specialty medications and such can cost people a lot. And so we try to remove that barrier as well. You also get Brent and Tasha and did anybody recognize this lady, fine lady up here? Coming to, either we have bubble packs, so if you have a hard time remembering what meds to take, what time of day, the pharmacist will work with you, and they coordinate with the provider to make sure you get exactly what you need at the time you need it. So you come in for your medical appointment, dental appointment, and just go downstairs and pick up your meds before you go. So we really don't want everybody to be running all over town trying to capture all these services in our one-stop shop. Behavioral health is another service that we added. I already mentioned the story about my daughter, but we really provide that whole person care. And it's not just counseling services and those types of things, but we have wraparound programs like social work or tenancy support, which is helping someone get housed and then stay housed. Lara mentioned Blue Heron Place, which is a permanent supportive housing unit. Does anybody know what that means? Anybody want to share?
Housing first.
Housing first. There you go. So once you get into housing, then we're there to provide services like social work, behavioral health. We have a medical clinic right next door so that you can stay housed. And then we also have insurance enrollment assistance. We're the only shop in town, I think still, that provides in-person counseling for that. I've actually gotten 16 calls from just friends of mine that are newly don't have their insurance and need some help. And so they've been able to get in with our enrollment counselors to get on the marketplace plans. We are also helping train tomorrow's providers. So we partner with the Family Medicine Residency Program of Western Montana, and it's a 2-for-1 because you get these fabulous providers that are just out of school at top medical schools with the best practices and the most recent information. And then they're supported by what's called a preceptor, which is also looking at those plans of care so that you can get 2 doctors for 1. So that's a very great part of our program. We're training all of those physicians, and 60 to 70% of the family medicine residents stay in Montana, and they serve the rural and underserved populations of this great state that we live in. So they're very proud. We're very proud of that statistic. So I think I'm going to turn it over to Jim. Sorry, Dr. Court.
How long do I have till?
You got 13 minutes right now.
All right. And it's going to take me at least 20 minutes to figure this thing out. So the innovative programs, I mean, one of the things that we're actually asked to do as a federally qualified health center is be in our community, have impact in our community, and then look to see where, look to see where there are gaps in the healthcare system. And I'm lucky enough to work here, and we get to do some really cool things and innovate in regards to how we're actually trying to bring care to the community. We already discussed the school-based health services and the behavioral health that happens in those locations. When we came in, everybody was sort of throwing out what's hard about healthcare. I mean, the number one thing that's hard about healthcare, I think, is getting there and finding the time. And we deal with a patient population that, maybe doesn't have transportation or stable housing, or, they're not sure if their insurance is intact when they get to us. So they're nervous about even coming. So this was, one of the things that we're doing in the community that I think is going really, really well, and we're very, very excited about for the reasons that Marge described. It's basically access of a critical necessity in the schools where the people who need it are at. The next thing that we do that's pretty cool and innovative, I think, is the mobile support team. So we actually are partners with the fire department on this, and we could not have done this without them at all. And it's a 911 mobile support team, which is basically 911 behavioral health. So if someone's having crisis within the community in the county, they have gone to Sealy before, these guys will respond, and they do it in a way that is really good at de-escalating what's actually happening in that moment. And the statistics in regards to how many people actually stay where they are, which is nice because we're responding to homes and various locations, is really high. The options in the community prior to this, not exclusively, were I'm going to take you to the emergency room, or I'm going to take you to jail, or I'm going to leave you here and I'm not sure how that's going to help. And it really does help decrease responses from the fire department. Those are all 911 calls. And it also decreases the time at which our police department actually has to stay on site. These are old stats, but I think the police typically spend about 15 to 20 minutes when they get called out in any particular location. Our on-call time for the mobile support team average was about an hour and 15 minutes at one point. So it just allows them time to kind of de-escalate while everybody else has an opportunity to kind of go out and meet the other needs of our community. So I'm gonna keep going. The Watershed Navigation Center we briefly discussed, and so there's permanent supportive housing there. The folks that are getting those permanent supportive housing units are typically the highest utilizers of care in the community. That can mean a lot of different things. That can mean going to the ER every other day. That can mean the police are, getting called to deal with them on a regular basis. There's multiple different ways that they kind of move up that list. And this particular model tries to get them in a house or an apartment in that setting. And that's shown pretty effectively to basically stabilize them in a place where one example was I can't take my psychiatric medicines if I'm living in the street because I'm too sedated and I'm not safe. So when I'm actually in a place where I can sleep at night and I'm safe, I can actually take the medication now that keeps me stable. Just sort of a huge win for everybody involved in that. We also have the Navigation Center, which is next to the permanent supportive housing. And basically it's providing just a way to navigate the system. We're right next to the jail. Another good story I heard was when you get discharged from the jail, or I don't know if you get discharged, you get let go, and you're in the parking lot, and you got your phone. And the only phone number in your phone is your dealer. And you don't know what your next step might be in that moment. And so right now they can take a left, get a little coffee. We have a partnership with the Justice folks, CJD, that has a representative there. We are doing some court stuff there too, via video to help people kind of get simple things knocked down. And also, I don't know if it's on there, one of the cooler things is it's a document repository. So if you get swept up, when you're homeless, all your stuff and your papers go with. And so we'll have a file in there where everybody can copy their important paperwork. And so if someone needs something, hey, I gotta go to work, I need my social security number so I can tell them who I am, and there'll be a copy there for them. They don't have to keep track of it. And that again has also been a huge example of a win in that setting. Community care team, this is basically street medicine. We have a provider and a nurse that are going out into the street, super active during Johnson Street when that was open. It's a little different now. It's kind of interesting where the unhoused are right now. They don't want to be found because of the ordinances that you kind of have to set up shop and then they'll come to you. And so we're seeing a little bit of a difference in how we're responding to that particular need in the community. So Can't tell where I am. Landscape of care. So one of the things that I was going to ask, I was supposed to ask a question at the other one too. But, and this feels really reductive, but I think I made it like way into medical school before I actually knew the definition of Medicare, knew the definition of Medicaid, and knew the difference when there was expansion and what did that mean. So I'm not going to test anybody here right now, but I think that's a really important thing to recognize, because when we're looking, nationally right now, these are terms that are just getting thrown out there all the time. And everybody gets to make their own decision, obviously, but it's so hard a lot of times to know the context, like what does that actually mean? And so maybe that could be a little group discussion as you're kind of thinking about it. And then Josh can't weigh in on this, but in expansion, this is for extra credit, there is a 90% federal dollar match for Medicaid. For extra credit, what is the match when there is no expansion from the feds?
72.
It's 57. Right. So Medicaid in Montana, why does it matter? Medicaid is access for a lot of people, and I think the expansion component of this is super important to talk about. When you look at the bottom there, the driving the Montana economy, workforce support, 7 in 10 adults work. A ton of children and a ton of very disabled people are on Medicaid. So that other 3 often really can't work. And that's just something to keep in mind. The economic impact in Montana with expansion is $775 million of federal spending that happens here, 7,500 state jobs, and improved access for the expandees, which is basically anybody who is below 138% of the federal poverty level in Montana. Does anybody know what the federal poverty level 138% is? Anybody know? It's $22,000 a year for one person. Obviously, it should climb double for 2, and it doesn't. It actually is a little slower than that. So it really is just helping people access care. Pretty passionate about this. Why? Because this keeps people out of emergency rooms. It keeps people from actually having to show up with something that they never were sure they could get taken care of until it's really, what's this bump that's been there for 3 years and I would have come in 2 years ago. So those are all important things overall. And then what does it do for Missoula? It expands local care. And as we kind of discussed, thousands of Missoulians are on this. It reduces the crisis reliance, so it lowers dependency on emergency department and jails. Key word as we're kind of moving through all this too is uncompensated care. So that's basically we, get some help with that. We do that. So does the emergency room. And what are the odds in our capitalist society that is truly uncompensated? Somebody is going to pay for that. And often it's, the folks in the room with decent insurance. There's a reason that sometimes the bills there are really high. It's like if I know that 30% of the people can't pay when they walk into my business, the 70 that can might have a little extra on their bill. So that's one way of thinking about that. There's some newer models that I think are really cool as we move forward. There's 2 things that I'm excited about. And this would be another group discussion you guys can have, is technology is going to blow up how we're actually doing medicine in the next 3 to 5 years, and it's already happening. Today, our EMR that we switched to, Epic, created an AI tool that you can basically prompt it, and it will sift through all of your previous record so that the provider that's seeing you that day gets this really quick synopsis instead of digging back through the slides. There's multiple instances where data sifting is actually going to be a really important part of what is helpful. And I would also say you can use these things for good and evil. And there's different ways to go about that. And the value-based care model is like, it basically means I'm going to pay you for quality. You guys do a good job. You take care of this subset of people, like 10,000 people, and it costs X. And that's actually a little less than it would have cost if you hadn't been involved in their care, because I'm going to front load your payment so that you can get social workers and help out there to kind of forego these emergency events. The way the healthcare system works right now is you get paid per unit. So if I see somebody, I get paid. If I do a surgery, I get paid. And it turns into a little bit of a volume game. And everybody here knows that, because if you've spent time with your primary care physician, it's measured in minutes. We're under an enormous amount of pressure to get in, figure out what's going on, and then get back out again. And that's not great, but it is sort of how the system and the game is played currently. And we are hopefully moving into a world where we get to change the game and make everything more efficient with technology, so that we get to spend more time with our patients and the people we care about and our community, and make sure we are providing the best care we can in Missoula and then in the great state of Montana. And scene. Half a minute. Actually, that's this. Oh, yeah, no, it's done. So thank you very much for your time.
All right. Thank you all for your presentations. We've come to the point in our meeting where we have table talk. This is the fun part. So if you have not been at a City Club meeting, this is where you get to talk to your table mates. So look around you, formulate a question or two in case that first question gets sniped by somebody else. You'll want to elect a speaker of the table. So Alex is going to be walking around with the microphone. He'll come to your table, ask if you have a question. If you do, go ahead and stand up. Say your name and then ask your question. We don't have too much time, so we don't want to get into backstories and a lot of different discussion there. So again, it's civil discourse and free exchange of ideas. So those questions will go directly to our panelists and they'll take them and answer them as they want. So go ahead and do your table talk and we'll come back in about 10 minutes. Also, there's extra food. Silk Road actually did 2 pieces of each one, and a lot of people just took 1 piece of food items. So go eat, please.
We're just starting. This recruiting gym was when we were just starting. We're working in watershed. Yeah. Oh, sorry. I'm Chelsea. Work for the county. Oh, hi. Sorry. Yeah. Great. I work for the Parks and Trails Department.
I trip over it every time I say it. That's just still so.
Wow. You guys fussy with I'm joking with fussy with the terrified to go to the gym.
I'm just messing around.
Somebody, yes, but yeah, don't forget.
I thought you were going to So group visits, there's a lot of classes, group classes.
The one that we currently have is closets.
I have some insurance and I have still versus Is that the question?
I know, but it feels like
Regardless,
yeah.
and it's
What do you just ask about pros and cons, barriers?
right.
Yeah, no, I did have a question. But I do have a question.
Everybody is involved either in nursery or health department or I knew it back in still that.
What's it called?
Yeah, there is, I guess I'm gonna be working.
Yeah, we've been gone for 20 some years to a variety of places. Her grandparents. So this is more home than it has been in the
You like those?
Yes.
I would imagine.
Actually, yes, probably. No, I think having
Yeah. To ask them. Me. Yeah.
when you see like there,
Well, it's odd because I was thinking about working telehealth-based substance use.
talking,
You're like, I'm just thinking that, probably there's kind of doing it.
That's the place where you're actually there.
Like, I don't know, that seems like it shouldn't be that hard. My license and my previous work is, I don't know. Yeah. I'm just finishing this post. Careless people on Facebook. Have you heard about it? Chilling. Talk about data sifting and oh my God.
Yeah, that was like a social blogger.
Yeah, I don't know. He is, it's very much so you're going to be our spokesperson, right? We're wondering what preparations are making for the Medicaid work requirement negotiation. Wondering if there'll be what else?
Ready to have two questions? Ready to start the
Couple more minutes and we'll get ready for table talk.
I mean, I'm sure there's.
That's something where AI can definitely help.
Yeah, they actually have a clinic, Monday to Thursday, where it's just like they do a partnership. So I'm pretty sure they're doing just like they do.
I don't know what the question is. I feel like they have so many kind of like.
All right. Our panelists are ready for rapid fire questions. So we'll go ahead and get started. So Alex again is going to bring the microphone over. Please raise your hand. He'll come around and you can ask your question.
Chad Bauer, President and CEO of Missoula Chamber of Commerce. And our question is how have operations changed at PHS now that you are not directly connected to the county?
Well, the short answer is not much. And I think both Dave and Josh can attest to that. It really was, as Lara said, it was really a financial thing, having to do more with HR and financials and how those are managed. Operationally, we've kind of continued on the way that we typically operate.
I'll just add, I think there was not major confusion, but sometimes there was confusion about, PHC has never received taxes in the way that other departments of the county are budgeted that way. And I recognize also the county and the city also generate revenue in other ways similar to we, but now we're able to sort of make that distinction for funders and that sort of thing. So that's one other way.
Hi, I'm Slavin Lee. I'm the director of the Missoula Public Library. We were wondering what preparations you're making for the Medicaid work requirement that goes in effect in December, and if you plan to offer any sort of community education related to that.
That's a great question. I think nothing other than what we do now. It's because, again, our commitment and the federal gift that we get, and our aim is always to be able to provide services regardless of ability to pay. I think it's things like this where we're trying to educate people and help bring people in so that they're not afraid of the work requirements in terms of access. We are also, Watershed is a place where people can go, as Marge mentioned, to get help in getting connected to work resources if people are not already working. So does that answer your question? Are you all doing work here at the library?
We probably should, yeah.
Let's get together and make a plan. Yeah, exactly.
We have flyers. We do. We have flyers.
Hi, I'm Audrey Handelman with Cushing Terrell, and this is the county table over here. Our question was around collaboration, and we were wondering how you collaborate with other nonprofits like All Nations Health and with private sector, sort of medical like community or St. Pat's or even private practices.
Great. So, I mean, collaboration, at least on the medical side, with our providers is often, more at that professional level where it's, we send people to St. Pat's, we send people to community, we send people to, other professional services like ENT in town, bone and joint. So those are sort of established in regards to how we're collaborating. When we think about All Nations, we've done work with them in the past, and we're always mindful of the patient populations that are supported by them and how we also can meet the need in that regard or help them succeed. It's about the patients, and so we all want to work together to kind of try and get to that end game where they're doing well, and the partnerships usually just kind of flow out of that. I mean, the one that I was, which isn't a volunteer but or nonprofit, was the fire department, would be a good example of sort of a non-traditional relationship that we fostered to actually come up with a solution that seems to be working halfway decent. And there's other opportunities, and you sort of have to kind of play the field and see where things align, like in a lot of things. And if you're both rowing in the same direction and it feels important, we've often partnered with people throughout the city.
I'll just add, I think we are constantly working on plans and trying to solve problems with the Pavarello Center, with the YWCA, with the city, with the county. We're at tables with Emily and her team. And so that is, I think, one of the things I'm so proud of about PHC is really this team's willingness. We have folks in the audience who are also part of our leadership team, and just nobody's afraid to reach out or set up a call, set up a meeting. How can we solve this problem? How can we work on this future thing? So it makes it really fun and exciting. And I think Missoula is particularly good at these relationships. So it makes it pretty easy, actually. So that answer your question?
Yes, thank you.
Okay.
Hi, thank you. My name is Jan, and I have a group from Sealy Lake here. So first of all, I want to say thank you for your services and clarification also for a lot of people in the room that don't know that you serve all incomes, and you've got a lot of people here that appreciate your services. My overarching question is, how do you define community? As a rural area of Missoula County, you described an array of services here of which we don't have access to. So I'm really curious how that plays out for those of us that are an hour away, yet part of the county. How do you define community, and how does that, what does the future for us look like, especially now with the complexities of healthcare? And I understand the deficits that are going to be approaching. Thank you.
It's a great question, and it's a challenging one, right? We have spent a lot of time in the Sealy community trying to understand, based on the population, based on the impact, based on the services that we've been providing there since 2014, how do we also navigate a landscape of financial sustainability so that we can provide services in any given place at any given time? So we have been providing medical and dental services in Sealy Lake for a number of years. And so when we think about community, when we took on the clinic at Sealy Lake in 2014, it's because of our mission and our model. And we also have to consider the whole organization as we think about the surrounding communities and how do we spread our services in the most cost-effective way. It is, to communities that are further out, right? So we're trying to think about that all the time. Is it that we also provide mobile services and telehealth services? So a lot of the services, and that's, I think, part of our outreach to Sealy community members is to help with innovative programs. How can we reach you better by telehealth? How can we reach other communities that are still in need better in those ways? How do we pay for a mobile service so that we can reach more rural places? So it does come down to cost, and it comes down to how do we spread our resources most effectively for the highest impact. So Sealy is absolutely part of our community, as is Lolo, as is the Bitterroot, as is the Y, as is going the other direction. And so trying to expand as best we can with those resources. Does that answer your question? Okay, any follow-ups there?
Yes, our table, I'm Jana Staten. I guess we'd like to know where you think the greatest threats are to your services, either from state or federal administrations. Where are they looking to possibly cut? And we had a whole list, like making people pay, the pharmacy, behavioral health, mobile support, which I think is threatened, the Medicaid expansion going away, refugee access. They all seem vulnerable, but we're kind of wondering where you are looking to worry the most.
All of that. No. The thing that probably what I was going to say is one of the things that's nice is actually when they just passed the CR and it kind of gives you a little bit of a temperature on whether or not what FQHCs are doing, what primary care support we have at the national level is where it's at. It's bipartisan, and when they passed the CR, our sliver of it, the CHCs, the federally qualified health centers, that actually went up in regards to the actual budget, which in our current environment is a huge win. That we would have been, I think, ecstatic if it had stayed static or even gone down a little bit. But to see that benefit, in that regard, federally qualified health centers have always been bipartisan, and so that's nice, at least on that side of it. I think that where we bump into trouble pretty quickly, both at the state and the federal level, is with Medicaid and what that will look like. One of the tables that asked about work requirements, really what that is if you were on Medicaid before, and I can't remember the exact timing of it, but you had to prove that your financial need was once a year you had to go, and they didn't have work requirements, and now work requirements, you're going to have to prove that you're working. We already said 7 out of 10 are, but just the administrative burden of actually trying, like every quarter or every 6 months, you've got to show somebody a letter saying, well, hey, I'm working now, feels like a real problematic area. I mean, we're basically asking a state agency, DPHHS, to administer or administrate that. And they're not exactly, sitting on a lot of funds, I think, to actually make that happen. So those are the kinds of things that we would love to be able to help out with in regards to making sure people are covered. But I think, our funding, we're okay at a, federal level, state level. I think the Medicaid and what that looks like. And I think just an overall overview of what the perception is of entitlements to people whom are, pulling those levers of the finances is what I would be most concerned about.
Just to add a little bit, you mentioned refugee. So we have a great refugee program, which the state continues to fund those that are here, but the volume of people that have come to Missoula has decreased. And so unfortunately, we don't have control over that part, but we are still taking care of all those folks that are here. And then also, speaking of partnerships, and Medicaid has also drawn on all of us FQHCs and CHC or community health centers from the state to develop the new program. The work requirements were not part of our suggestion, but they're also working on making sure that like hospital tracking is really well coordinated, so that once you might be in the hospital, that we're following up with you and what that looks like, and they are determining some ways that we can do that. So they have partnered with us in asking for help in developing that, which is a new thing. Before it was just here's what you have to do, and now they're really asking for our help. So that's been a great partnership as well.
Hi, I got a question again from Sealy Lake. Thanks again for your services. I just want to get real specific here because Partnership Health Center has cut the services from 5 days to 4 days. There are fewer doctors, so we have to chase doctors back to urban areas. And the legislator had a hearing last fall too, after you all came up and gave your presentation in Sealy Lake, talking about the federal cuts to healthcare, $1 trillion in Medicaid over 10 years. Cuts to the ACA subsidies and Medicaid expansion, ACA subsidies, Medicare provider reimbursement rates. So it's all going down. And you said you run at a deficit of $350,000 in Sealy. Are you going to have to make cuts in Sealy Lake for provider services? What happens in rural areas, as Pete said here from Sealy Lake, the fewer patients you get in Sealy Lake that get reimbursed, they go to urban areas and they get the reimbursement. We lose reimbursement. So it's weakening the rural system and strengthening the urban system. So are you going to make cuts in Sealy?
So I'm going to be super frank because this is a really great conversation and it's an important one, right? So Partnership is operating in Sealy to the best of its ability. There are 1,900 residents in the community. That's what one provider is typically handles at our urban sites, right? So it's more expensive per, and we're going to get into the financial part, which is hard because this is about humans, but this is the crux of the conversation, right? So it's more expensive per visit for Partnership to provide care in or any of the health centers in a rural community because of the cost of transport, because it's hard to find providers who will reside there, because it's not as close to other services. Those are just the things. So what ends up happening, and this is completely valid and reasonable, it's that the health agencies that are really trying to provide those services in rural communities are the focus. Our focus needs to be, every one of us, on the systems, right? The systems of care that make it challenging for organizations that have to pay the same cost of living, salaries, all of benefits, all of those things, transportation, figuring out a way to provide that care in rural communities. When I say that, that's hard for Sealy Lake, right? Because you live there and you are generating an economy there, and it's easier, it's more, it's hard to talk about the system that is creating those conditions. It just is, because it's not as tangible. It feels a little more easy to, say it's the health agency's fault. And I know that that's not what you're saying, but I think it's important for us to talk about that, all of us, with with folks who we know about the system that should be supporting the higher cost of care in rural communities. And I hope we can keep doing that, because we do have to put our resources, especially because they are federal resources, in the places where there will be the greatest impact. That's what the federal government asks us to do. And meanwhile, we are committed to Sealy Lake because you are part of our community and we do care about you. And we're doing the best we can, and we will keep doing that as long as we possibly can. And yes, we are concerned about the cuts that are impacting those rural communities. And so, again, it's.
Have you penciled that out yet for Sealy, whether you will make cuts?
Whether we will make cuts in the future? Well, I mean, I think the $300,000 loss that we experience in Sealy each year, yes, we need to cover that. So it's unclear whether we're going to, what kind of cuts, right? So we have to look at all kinds of cuts. Is that staffing cuts? But we don't, right? That's not in our plan at this point. But those are the kinds of things that all healthcare agencies are doing. And, hospital systems are closing rural sites. We don't want that to happen, but it is happening. And we're doing our best to stave that off. So yeah, thank you.
Thanks. I'm Peggy Kaur, and like many people here, our table talked about money. So we are just wondering, in general, where does your money come from? What percentage is federal? Do you solicit donations, private, personal donations? How does that work in general, please?
Yeah. It's a great question. So we have what's called a payer mix. And so about 32 to 34% comes from Medicaid. And you're gonna go, that doesn't equal 100%, but I'm gonna try this. So it's like, 16% is, payers or commercial insurance. It's between 16 and like 20. It fluctuates, right? And then we have probably 20% that are on our sliding fee scale. So they may pay $5, they may pay $100, depending on their income level. But comes from billing, and then Medicare is sort of the balance of that. So from commercial insurance, from Medicare, Medicaid, and self-pay. The federal grant that we are eligible for is about 10% of our overall budget. So it's not a huge amount, but it allows us to cover the cost of folks who cannot, who don't have any resources. And then yes, donations, and that is where making it clear that we have always been a nonprofit and that we do not receive tax dollars has been beneficial for both us and the county to make that clear, so that we can ask donors for support and in that fundraising. We also apply for lots of other grants. We have our development director here in the room, who's covering her face now, but that's really important too, is to apply for other funding resources. Always doing that. Anything else? Cover it.
Hi, my name's Hatton. Hi, Lara. Hi, Jim. I have a question about maybe grants or this extra funding angle. To what degree are federally qualified health centers available to apply for the Rural Health Transformation Program grants coming into Montana? And could that help this friction that we're hearing about in some of the rural clinic sites?
Yeah, that's sorry, I'm hesitating because that process is not entirely clear yet, and we are watching it closely. Our association is watching it. FQHCs are identified in the plan, but and then there are 5 buckets. I see people nodding your head as though you're familiar with sort of. There's just a bit of a lack of clarity. We'll find out probably more this week. There's a webinar Wednesday. And so it's not certain how those funds are going to be distributed, whether we would apply for them independently. My dream would be that we could apply as a community and distribute it in the way that addresses our needs as a community. And also, other communities rural communities like Sealy Lake, hopefully will also be benefiting from that. So we are paying close attention to it. We are involved in, whatever that will look like. So we'll know more this week. Anybody else have more information than that?
No, that's pretty much what.
Okay. Those were fantastic questions. Thank you for challenging us. That really does allow for very frank conversations that need to happen. So.
I did have a quick question, and Jim, when you mentioned something about AI in medical, and maybe somebody asked this, but you said that there was some good and there's some bad that come with that. Can you kind of expand on the good side and, pardon me, on the bad side as well when it comes to the AI in medical?
I think the easiest example is, one of the things I'm focusing on right now is the use of that technology to diminish the amount of time that I'm paying a very highly skilled medical professional to be a data entry analyst. There's something called ambient scribing now. It's actually getting used in the community, and we're moving in that direction where basically your doc will come in and say, hey, I'm going to record this and it's going to help me write my note, and I can be face to face with you now. When I walk out of the room, my note will be like 90% done, which is a huge deal. You ask any primary care physician what they're doing their notes, whether it's Saturday morning, Friday morning, their day off. The amount of paperwork generated by one family physician in a day generates about 24 plus hours of paperwork. So you can imagine like we're all just swimming in it. And so there's going to be some real opportunities, as I was kind of mentioning about the data sets. It's like, that's just, ones and zeros to somebody. And so if we can figure out a way to actually facilitate that part of everybody's experience in the room, I think that there's going to be some amazing changes. We're currently looking at a product right now which is supposed to save one primary care physician 5 hours a week in regards to their overall paperwork, and that's an average. Where I think we all need to worry a little bit is, insurance companies have AI, and I think that's been in the news of late too. And so if I'm using AI to, work your medical record for a denial, there isn't a huge, opportunity for someone to create AI, or there's not a lot of money behind the AI that's going to block the insurance company from doing that. Maybe there should be. Anybody's a venture capitalist, I'd love to chat with you. But I mean, it feels like that sort of tug of war is really going to be very evident. Like another thing that I just saw that's helpful for us is a prior authorization. You come in, I say you need this, your insurance company is like, well, can we talk about it? You need to authorize this. Well, that's a phone call, it's a fax, it's a piece of paper, which is infuriating at this point. I got to sign it. It goes to the wrong place. It goes to the right place. It doesn't go to that fax number. And there are actually AI bots that will scrub electronic medical records now so that we give them whatever the answer is. I have literally had conversations with patients, and this is maybe more a reflection on me, where they'll say, like, well, what do you have to say? And I'll be like, I don't know what they want from me at this point. I put all the stuff in there that I thought was pertinent, and you kind of just throw these at the wall like spaghetti, and then they'll be like, oh, well, that one worked. It's like, great, I finally get to get you the thing that you need. And so much of that, I think, at some level too, like impacts the moral injury of practicing in this very broken system that we have. No one wakes up in the morning thinking, I wanted to do whatever it was, 12 years of education to, ace my prior authorizations. Like, that is not why we go into medicine. And I think that, some of the turnover that you may see in the primary care workforce throughout Missoula, it's not uncommon, happens a little bit everywhere. And it's a really tough job. And I think that AI has a huge opportunity for us to, sort of save that and save a whole lot of good docs that are swimming underneath a lot of paperwork. So fingers crossed, that would be the AI for good.
Cool, thank you. One more round of applause for our three panelists, Lara, James, and Marge. Again, thanks to our executive level sponsors, Blackfoot Communications and First Security Bank. And of course, Sam at Soak Road, there is still a ton of food. So if you go out this door and take a left, there's a lot left. So grab one on your way out, please. So we're gonna go from half a room to a full-sized room. Our State of the Community is next month. We're proud to present Andrea Davis, the City of Missoula Mayor, Josh Slotnick, a Missoula County Commissioner, and Dr. Leslie Webb, who's a Vice President of Student Affairs and Enrollment Management. So she will be here from the university. So we're gonna try to open the registration for that meeting this Wednesday. We're going to have to cap it because that gets to be fairly large. It'll be again in this room. So please check out our website. Please register. Hopefully by Wednesday, and we will. We'll see you next April. This April, not next April. This April. Thanks all.
Nice meeting you.
We didn't have to field the question.